A Comprehensive History of Novo Nordisk, 1921 to 1989. The history of Novo Nordisk is a seminal case study in the evolution of the global pharmaceutical industry, illustrating how a bitter local rivalry can serve as a catalyst for global dominance. This review provides an exhaustive analysis of the 70-year period preceding the 1989 merger that created the modern corporate entity. It traces the origins of insulin production in Scandinavia, sparked by the Nobel laureate August Krog's personal mission in 1922, and details the acrimonious schism in 1924 that spawned two competing firms, Nordisk Insulin Laboratorium and Novo Therapeutic Laboratorium. The analysis explores the distinct corporate cultures that emerged, Nordisk's academic paternalism versus Novo's aggressive commercial innovation, and how these diverging philosophies allowed the Danish insulin industry to survive the geopolitical traumas of World War II. It examines the intense technological arms races of the post-war era, specifically the competition between NPH and Lente insulins, the quest for monocomponent purity, and the existential threat posed by recombinant DNA technology in the 1980s. Finally, the review dissects the complex economic and interpersonal dynamics that led two lifelong adversaries to merge in 1989, forming a unified front against global competitors like Eli Lilly. The pre-insulin era and the Danish connection. To comprehend the magnitude of the industrial developments in Denmark during the 1920s, one must first contextualize the medical reality of diabetes mellitus prior to 1921. For millennia, diabetes was a poorly understood and uniformly fatal condition. The sugar sickness was characterized by an unquenchable thirst, rapid weight loss, and eventual coma and death. By the early 20th century, the only known management strategy was the starvation treatment, pioneered by specialists such as Dr. Frederick Allen and Dr. Elliot P. Joslin. This regimen essentially starved the patient to delay the onset of ketoacidosis, trading a quick death for a lingering, emaciated survival. In this environment, a diagnosis of type 1 diabetes in a child or young adult was a catastrophic event, typically carrying a life expectancy of fewer than 2 years. It was against this backdrop of desperation that the scientific community searched for the internal secretion of the pancreas, a hypothetical substance believed to regulate blood sugar. The Danish entry into this field was not driven initially by corporate ambition, but scientific prestige and personal necessity. August Krog, 1874 to 1949, was a titan of European physiology. A professor at the University of Copenhagen, he had dedicated his life to the study of the mechanics of gas exchange in living organisms. His groundbreaking work on the capillary motor regulating mechanism, demonstrating how capillaries open and close to regulate oxygen supply to muscles, earned him the Nobel Prize in Physiology or Medicine in 1920. August's wife Marie Krog, Mary Jorgensen, was a formidable intellect in her own right. In 1914, she became only the fourth woman in Denmark to earn a doctorate in medicine. She was a practicing physician and a researcher, collaborating with her husband on studies of gas exchange and working on heart medicines for Lowen's chemical fabric. But her scientific journey took a sharp personal turn in 1921. Marie Krog was diagnosed with diabetes. Although she suffered from what is now classified as type 2 diabetes, late onset, the diagnosis was terrifying in an era before insulin. It was this diagnosis that transformed August Krog from a disinterested physiologist into a motivated conduit for one of the greatest medical transfers in history. In 1922, August Krog was invited to the United States to deliver a lecture tour at Yale and other prestigious universities, ostensibly to celebrate his recent Nobel Prize. Marie accompanied him. While the public purpose was academic dissemination, Marie had a private agenda. She had heard rumors of a miracle occurring in Toronto, Canada, where a team of researchers had successfully isolated insulin. During their travels in the US, the Krogs dined with Dr. Elliot P. Joslin, the preeminent American diabetologist. Joslin confirmed the rumors. The Canadians, Frederick Banting and Charles Best, working under J.J. MacLeod, had not only isolated insulin, but were successfully treating patients. Joslin urged the Krogs to visit Toronto. Marie, driven by her own condition and her perspective as a physician, persuaded August to adjust their itinerary. The Toronto Agreement and the birth of Nordisk, 1922-1923. In November 1922, August and Marie Crowe arrived at the University of Toronto. They stayed as guests of Professor J.J.R. MacLeod, a fellow physiologist whom August knew professionally. The timing was fortuitous. The Toronto team had made the breakthrough, but was struggling with the immense challenges of scaling production and purifying the extract to prevent painful abscesses at injection sites. They were overwhelmed by the global demand for the life-saving fluid. August Crowe's reputation as a Nobel laureate smoothed the path. He proposed that he be allowed to bring the extraction and purification protocols back to Denmark to establish production for Scandinavia. The Toronto Committee, recognizing Crowe's capability and the humanitarian need, agreed. They granted him the authorization to manufacture insulin, with one critical stipulation. The production was to be non-profit. Any surplus revenue generated from the sale of insulin was to be reinvested into scientific research or used to lower the price of the drug for the poor. Upon returning to Copenhagen in December 1922, Crowe wasted no time. He carried with him the license and the technical knowledge, but he lacked the clinical and industrial infrastructure. He immediately recruited Dr. Hans Christian Hagedorn, 1888 to 1971, a brilliant physician who had written his doctorate on blood sugar regulation. Hagedorn would provide the clinical oversight and the method for testing insulin potency. The third pillar of the foundation was capital and manufacturing capacity. The Crowes turned to August Kongsted, the owner of Lovens Kemiske Fabrik, Leo Pharmaceutical Products. Kongsted was a pharmacist and industrialist who possessed the necessary capital to underwrite the risk. He agreed to finance the startup phase and provided laboratory space in his factory. In exchange for his financial backing, Kongsted required that the first Danish insulin product be named after his company's symbol, the lion. Thus, the product was named Insulin Leo. The speed of execution was remarkable. Experiments began in Hagedorn's villa in Hellerup and at the Leo factory. By the spring of 1923, the team had successfully extracted insulin from bovine pancreases. On March 13, 1923, the first patients were treated at the Kommune Hospitalet in Copenhagen. In May 1923, the entity was formally established as Nordisk Insulin Laboratorium. Adhering to the Toronto principles, the company was structured to serve the public good. In 1926, the Nordisk Insulin Foundation was created to hold the assets, ensuring that profits would support physiological and endocrinological research. This structure established Nordisk's corporate identity: academic, high-minded, and deeply integrated with the scientific establishment. The Great Schism, the Pharmacist versus the Doctor, 1924 to 1925. While Nordisk's founding was rooted in high ideals, its operations were dependent on practical engineering. This reliance on technical staff led to the conflict that would fracture the Danish insulin industry and create a rivalry spanning the rest of the century. To manage the physical production of insulin, Nordisk hired two brothers who would prove to be pivotal figures in pharmaceutical history: Harold and Thorvald Petersen. Harold Petersen was a mechanical genius. Originally a smith, He had lost an eye in a workplace accident and subsequently became the manager of the mechanical workshop at August Krog's zoophysiology laboratory. Krog brought him to Nordisk to design the machinery needed to process animal glands. Harald invented a specialized machine capable of shaving frozen pancreases into thin slices, which fell directly into acidified alcohol for extraction, a crucial innovation that increased yield and efficiency. Thorvald Petersen was Harald's brother and a trained pharmacist. He was hired in the autumn of 1923 from Dansk Sojakagefabrik to oversee the chemical analysis and purification processes. Thorvald was ambitious, pragmatic, and proud of his pharmaceutical expertise. The friction at Nordisk was fueled by a clash of personalities and class. Dr. Hagedorn was an aristocrat of science, stern, demanding, and protective of his medical authority. He viewed the Petersen brothers as technicians, essential but subordinate. Thorvald Petersen, however, saw himself as a co-creator of the production process. He chafed under Hagedorn's rigid management style. The conflict came to a head in April 1924. While the exact details of the final argument were never recorded, the outcome was decisive. Hagedorn fired Thorvald Petersen. In a display of fierce loyalty, Harald Petersen resigned immediately. The departure was marked by a famous exchange between August Krog and Harald Petersen, which has since entered corporate mythology. When Krog asked Harald what he intended to do, the machinist replied, "We want to make insulin." Krog, perhaps underestimating the brothers' resolve or overestimating the difficulty of the task without Hagedorn, retorted, "Well, you'll never manage that." Harald's final words were a declaration of war. "We will show you." The Petersen brothers did not have Nobel Prizes or established pharmaceutical factories. What they had was the technical know-how they had developed at Nordisk and a burning desire for vindication. They set up makeshift laboratories in the basement of Harald's villa in Frederiksberg. They named their venture Novo Therapeutic Laboratorium, Novo being Latin for new, signaling a fresh start and a direct challenge to the old guard at Nordisk. Working with intense speed, the brothers succeeded in producing a stable liquid insulin. On February 16, 1925, they sent a letter to Danish pharmacists announcing the availability of insulin Novo. They also introduced a key innovation, the Novo syringe. Designed by Harald, this syringe was easier for patients to use, marking the beginning of Novo's user-centric design, a strategy they adopted to differentiate themselves from Nordisk's clinician-centric approach. Before fully committing to independence, the brothers reportedly offered to collaborate with Nordisk, hoping to sell their improved product through the established company. Krog and Hagedorn rejected the offer. This rejection sealed the fate of the Danish industry. There would be two companies locked in perpetual competition. Divergent Cultures and the Hospital War, 1925 to 1939. For the next 15 years, Novo and Nordisk developed along parallel but distinct tracks. The rivalry was not merely commercial, it was cultural, defining how each company approached research, marketing, and patient care. Nordisk Insulin Laboratorium remained deeply entrenched in the scientific establishment. Under Hagedorn's leadership, the company prioritized physiological research over commercial expansion. The profits funneled into the Nordisk Insulin Foundation supported grants for independent research, solidifying Nordisk's reputation among the medical elite. In 1932, Hagedorn realized a long-held dream by establishing the Steno Memorial Hospital, Niels Steenson's hospital. Dedicated exclusively to diabetes research and treatment, the hospital became a global center of excellence. It operated on Hagedorn's philosophy of rigorous dietary control and precise insulin titration. For Nordisk, the hospital was the heart of the enterprise, ensuring that their product development was guided by direct clinical observation. Novo, lacking the academic pedigree of Nordisk, adopted a more aggressive commercial strategy. The Pedersen brothers focused on export markets and manufacturing efficiency. While Nordisk dominated the Danish market through its connections with the medical establishment, Novo looked outward, building a network of agents across Europe. To counter Nordisk's clinical advantage, Novo opened its own specialized hospital, the Hvidovre Diabetes Sanatorium, in 1938. While Steno was known for its scientific rigor, Hvidovre developed a reputation for a more patient-friendly, holistic approach to diabetes management. This hospital war between Steno and Hvidovre drove standards of care in Denmark to world-leading levels, as the two institutions competed to demonstrate superior patient outcomes. The rivalry intensified in the laboratory. In the mid-1930s, the holy grail of diabetes research was retard insulin, a formulation that would release slowly into the bloodstream, reducing the need for frequent injections. In 1936, Hagedorn and his team at Nordisk made a breakthrough. They discovered that adding protamine, a protein extracted from the sperm of river trout, created a precipitate that dissolved slowly in the body. This discovery led to the development of NPH insulin, which was finally perfected and launched in 1946. NPH allowed patients to maintain basal insulin levels with fewer injections. Because Nordisk held the patents on the protamine method, this gave them a significant technological lead and threatened to marginalize Novo. Novo responded by diversifying. In 1938, they utilized their gland processing infrastructure to begin manufacturing sterile catgut for surgical sutures, derived from sheep intestines. This diversification provided a critical revenue stream that helped stabilize the company during periods of intense competition. The Dark Years: Occupation, Ethics, and Survival, 1940 to 1945. On April 9, 1940, Denmark was invaded by Nazi Germany. The occupation, which lasted until May 1945, presented an existential threat to the insulin manufacturers. Denmark's economy was tightly integrated into the German war machine, and import channels for raw materials were severed. The most critical shortage was the supply of pancreas glands. As feed became scarce, livestock slaughter decreased, threatening the insulin supply for the entire continent. The ethical landscape was treacherous. Both companies continued to produce insulin, which was essential for the survival of Danish diabetics. However, they were also compelled to supply insulin to the occupying forces and to markets in German-occupied Europe. This created a complex dynamic of collaboration and resistance. While maintaining production was a humanitarian necessity, it also technically aided the German economy. Despite the forced economic cooperation, historical evidence indicates that the companies played a double game. Elements within the leadership and workforce of both Nordisk and Novo were actively involved in the Danish resistance movement. Specifically, they supported Holger Danske, one of the largest and most militant resistance groups in Denmark. Factories and warehouses, with their legitimate traffic of trucks and chemicals, provided ideal cover for illicit activities. Novo's facilities were reportedly used to hide weapons and supplies. Funds were diverted from the company's accounts to support the families of imprisoned resistance fighters and to finance sabotage operations. This support was dangerous. Discovery by the Gestapo would have meant execution for the leadership and the destruction of the factories. The Holger Danske connection remains a proud, albeit quiet, chapter in the corporate history, illustrating how the non-profit DNA extended to national survival. Nordisk's business model relied heavily on international scientific networks and licensing agreements, particularly with partners in the United Kingdom and the United States via the Toronto connection. The German occupation severed these ties. Nordisk could no longer communicate with its Anglo-American partners, nor could it receive royalty payments. The company effectively went into hibernation, focusing on maintaining supply for the domestic Danish market, but unable to pursue international growth. Its rigorous ethical stance and close ties to the Allied scientific community made cooperation with the German occupiers anathema to its leadership. Novo, with its strong manufacturing base and export focus within continental Europe, faced a different reality. The German occupying forces viewed insulin as a strategic medical supply. They directed Novo to ramp up production to supply not only Denmark, but the entirety of Fortress Europe, including Germany, Austria, and occupied France. This mandate presented a profound ethical dilemma: collaboration with the occupier versus the humanitarian imperative to provide life-saving medicine. Novo chose to expand. The material shortages of the war forced Novo into a desperate innovation that would change its destiny. With pancreas glands in short supply, Novo could not survive on insulin alone. They realized that the same glands used for insulin contained other valuable enzymes. They developed a process to extract trypsin from the pancreas residue left after insulin extraction. Trypsin was a proteolytic enzyme used in the tanning industry to soften leather, a material in high demand for military boots and equipment. By selling trypsin, Novo subsidized its insulin production. This pivot to industrial enzymes was the birth of Novo's second leg of business, which would eventually grow into Novozymes, the world's largest enzyme producer. Simultaneously, the war spurred interest in antibiotics. Penicillin had been discovered but was not yet mass-produced in occupied Europe. Novo launched a crash program to isolate the penicillium mold. In a famous anecdote of corporate lore, employees were instructed to scrape mold from old ski boots and jam jars to find a strain capable of producing the drug. This scavenger hunt science was successful. By 1947, Novo became one of the first companies in Europe to produce stable crystalline penicillin, diversifying its portfolio and securing its post-war future. The company utilized its efficient production processes to meet the massive demand. Consequently, while Nordisk stagnated, Novo's production capacity and revenue exploded. By the end of the war, Novo had transformed from the smaller challenger into the dominant insulin producer in Europe, surpassing Nordisk in both volume and financial resources. Post-war, this disparity in fortune required Nordisk to rebuild its international standing, while Novo had to navigate the political complexities of its wartime growth. However, the capital accumulated during the war allowed Novo to invest heavily in post-war research, setting the stage for the next phase of the rivalry. The post-war chemistry wars, 1946 to 1970. The decades following World War II were defined by a chemistry war, as both companies sought to out-innovate the other in insulin formulation. In 1946, Nordisk launched NPH insulin, which rapidly became the global standard for intermediate-acting insulin. Novo was locked out of the NPH market due to patents. Facing a crisis, Novo's researchers, led by Knud Halles-Moller, embarked on a desperate search for an alternative method to prolong insulin action without using protamine. In the early 1950s, Halles-Moller discovered that by combining insulin with zinc in an acetate buffer instead of the phosphate buffer used by Nordisk, the insulin formed stable crystals that dissolved slowly. This resulted in the Lente series, Lente, Semi-Lente, and Ultra Lente, launched in 1951-1952. The Lente insulins were a triumph. Not only did they circumvent Nordisk's patents, but they were also protamine-free, which reduced the risk of allergic reactions. The success of Lente re-established the balance of power, proving that Novo could compete with Nordisk not just on manufacturing efficiency. As the Pedersen brothers aged, they sought to secure the long-term future of their company. Unlike Nordisk, which had been foundation-owned since the 1920s, Novo was a private partnership. In 1951, the brothers established the Novo Foundation. The mandate of the Novo Foundation differed significantly from that of the Nordisk Insulin Foundation. While Nordisk's foundation focused on scientific philanthropy, the Novo Foundation was explicitly charged with corporate interests, ensuring the survival and optimal development of the company. This structure protected Novo from hostile takeovers and fragmentation, providing a stable ownership platform for aggressive expansion. By the 1960s, the focus shifted from duration of action to purity. Insulin was still extracted from animal pancreases, cows and pigs. Impurities in these extracts, such as pro-insulin, glucagon, and somatostatin, caused patients to develop antibodies, leading to resistance and lipodystrophy, loss of fat at injection sites. Novo invested heavily in chromatographic purification technologies. In 1973, they introduced monocomponent insulin, a preparation so pure that it was virtually undetectable as foreign by the human immune system. This was a marketing and clinical coup. The MC branding became synonymous with quality, forcing Nordisk to upgrade its own purification processes to compete. The purity war drove the quality of animal insulin to its theoretical limit. During this period, Novo leveraged its fermentation expertise to diversify beyond pharma. In the 1960s, Novo developed the production of industrial enzymes, specifically alkylase, for use in detergents. This business grew rapidly, eventually making Novo the world's largest producer of industrial enzymes. This diversification provided Novo with a second leg of revenue, creating a financial buffer that Nordisk, which remained focused almost exclusively on diabetes and growth disorders, did not possess. Financial maturation from Copenhagen to Wall Street, 1974 to 1981. Despite their technical successes, both Danish firms were minnows compared to the sharks of the global pharmaceutical industry. Developing new drugs and building enzyme factories required massive capital. The Danish stock market was small, illiquid, and insular. Novo, led by the visionary CEO Mads Uvlesen, recognized that to compete globally, they needed access to global capital. In 1973, Novo Therapeutic Laboratorium merged with Novo Industry to form Novo Industry AS. The following year, 1974, Novo listed its B shares on the Copenhagen Stock Exchange. The A shares, carrying the majority of voting rights, remained with the Novo Foundation, preserving the brothers' vision of independent control. This listing introduced a new discipline to the company: financial reporting and external scrutiny. But it wasn't enough. The oil crises of the 1970s had strained the Danish economy, and capital was expensive. The defining moment for Novo's globalization came in 1981. Under the leadership of Mads Uvlesen, Novo became the first Scandinavian company to list on the New York Stock Exchange, NYSE. This was not merely a financial transaction, it was a cultural transformation. To list on the NYSE, Novo had to adopt U.S. Generally Accepted Accounting Principles, GAAP, and meet the rigorous transparency requirements of the SEC. This forced Novo to become more professional, open, and commercially aggressive than its Danish rival. To navigate this, Novo hired Goldman Sachs. The investment bank orchestrated a sophisticated roadshow, introducing this obscure Danish insulin maker to Wall Street investors. They utilized American depository receipts, ADRs, to allow U.S. investors to buy the stock easily. In 1981, Novo rang the bell on Wall Street. The listing raised significant capital, $60 to $100 million in various tranches, allowing Novo to fund massive R&D projects and expand its U.S. sales force to challenge Eli Lilly directly on its home turf. Nordisk, by contrast, remained a private, foundation-owned company until 1984, when it finally listed on the Copenhagen Stock Exchange as Nordisk Gentoft AS. However, it lacked the deep access to global capital that Novo had secured. The Genetic Threat and the Tech War, 1980 to 1988. The 1980s brought an existential threat that overshadowed the local rivalry: the advent of recombinant DNA, rDNA, technology. In 1978, Genentech, a biotech pioneer in California, successfully synthesized human insulin using genetically modified E. coli bacteria. This meant that insulin could be produced in unlimited quantities without relying on the slaughter of pigs and cows. Genentech licensed this technology to Eli Lilly, the American giant that controlled the U.S. market. In 1982, Lilly launched Humulin, the world's first biosynthetic human insulin. The marketing narrative was powerful: human insulin for humans. This posed a direct threat to the Danish business model, which was built on the world's most efficient supply chain for animal pancreases. Novo, the master of the pancreas supply chain, initially misjudged the speed of this transition. They bet that they could produce human insulin by chemically modifying pork insulin. Pork insulin differs from human insulin by only one amino acid, alanine at position B30, whereas human has threonine. Novo developed an enzymatic process to swap this amino acid. They launched this as human monocomponent insulin in 1982. While it was human insulin, it was still tethered to the economics of pig glands. It was a semi-synthetic solution in a biosynthetic world. Lilly's Humulin, marketed as pure and technologically superior, began to erode Novo's market share, particularly in the US. Novo realized it had made a strategic error. It had to pivot to fermentation. Playing catch-up, Novo's scientists chose not to copy Lilly's E. coli method. Instead, they developed a proprietary platform using yeast, Saccharomyces cerevisiae. Yeast fermentation offered advantages in yield and safety. In 1987, Novo finally launched its own fully recombinant human insulin. The company had survived the biotech scare, but the delay had cost it dearly in the US market, enforcing the need for scale to fight American giants. While Novo struggled with the biotech transition, it revolutionized the experience of diabetes. For 60 years, diabetics had lived like heroin addicts, drawing fluid from vials into syringes, often in public bathrooms to avoid staring eyes. It was a stigma-laden, cumbersome process. In 1985, listening to patient feedback, Novo launched the Novo pen. It looked like a luxury fountain pen, used pre-filled insulin cartridges, and allowed for discrete dialing of doses. The impact was psychological as much as medical. It restored dignity to the patient. The Novo pen created a new market segment: durable devices and cartridges, which commanded higher margins than vials. Nordisk attempted to follow, but the Novo pen set the design standard that dominates the industry to this day. This innovation proved that knowing the patient was as important as knowing the molecule. It revolutionized life for people with diabetes, shifting the market focus from which insulin is purest to which system is easiest to live with. The Novo pen captured a massive share of the European market and cemented Novo's reputation for patient-centric innovation. Convergence, the path to the merger, 1988 to 1989. By 1988, the civil war between Novo and Nordisk had lasted 64 years. While it had driven innovation, it was becoming an unaffordable luxury in a globalizing market. The global insulin market was changing. Eli Lilly was aggressively using its size and rDNA advantage to pressure the Danes. Although Novo and Nordisk combined controlled over 50% of the world insulin market, Novo 34%, Nordisk 20%, they were fragmented. They were spending vast sums competing against each other in marketing and R&D, duplicating efforts while the real threat came from Indianapolis, Lilly, and Frankfurt, Hoist. Furthermore, the next generation of diabetes care, insulin analogs and GLP-1 agonists, would require R&D investments that neither company could easily afford alone. The cultural animosity between the firms was deep. Employees at Novo were blue and employees at Nordisk were green, referring to their logos. They had been trained for decades to view the other as the enemy. However, the leadership, Mads Ovlesen, CEO of Novo, and Henry Brenham, CEO of Nordisk, recognized the reality. In 1988, they began secret negotiations. These meetings were highly confidential, often held in private locations to avoid leaks that could destabilize the stock prices or cause a revolt among the staff. The negotiations were complex, a merger of equals structure that respected the heritage of both. In January 1989, the merger was announced. Novo Industry AS and Nordisk Gentoft AS merged to form Novo Nordisk AS. The share exchange ratio gave Novo shareholders approximately 62% and Nordisk shareholders 38% of the new company. Crucially, the Novo Foundation and the Nordisk Insulin Foundation merged to form the Novo Nordisk Foundation. This new foundation would hold the controlling A shares of the merged company. This ensured that the company would remain Danish, independent, and protected from hostile takeovers, while continuing the mandate of supporting scientific and humanitarian causes. The merger became effective in 1989. Mads Ovlesen became the president and CEO, while Henry Brenham served as co-CEO until his death in 1990. The integration was painful, involving the harmonization of two fiercely proud cultures. Yet the logic was undeniable. The combined company possessed the world's best insulin production technology, the world's best delivery system, Novo's pen, and the financial scale to dominate the global market. The post-merger genesis and the search for identity, 1990 to 1995. In the early 1990s, the newly formed entity faced the monumental task of integrating two distinct corporate cultures. Nordisk Gentoft was deeply rooted in a foundation-led academic tradition initiated by August and Marie Crow, while Novo Industry, founded by the Peterson brothers, had developed a more aggressive commercial and engineering-focused mindset. The friction between these operational philosophies could have paralyzed the company. Instead, management utilized the early 1990s to synthesize a unique Novo Nordisk way. This period was characterized by internal stabilization and the rationalization of manufacturing portfolios, setting the stage for the company to defend its insulin turf against Eli Lilly, the encroaching American titan. While the corporate offices were busy with integration, the R&D labs were refining the technologies that would define the company's future. The 1990s saw the maturation of recombinant DNA technology, which Novo had pioneered in the 80s to produce human insulin. By 1990, the transition from animal-sourced insulin to biosynthetically produced human insulin was largely complete, positioning Novo Nordisk as a leader in industrial biotechnology. Simultaneously, the company was advancing its enzyme business. Although eventually spun off, the enzyme division's mastery of fermentation technology in the 1990s provided crucial cross-pollination of expertise for the pharmaceutical division's protein engineering efforts. The shared scientific heritage of fermentation tanks, used for both penicillin and insulin, and industrial enzymes, created a manufacturing competence that competitors lacking an industrial enzyme arm found difficult to replicate. The era of the triple bottom line, 1990 to 1999. The defining corporate innovation of Novo Nordisk in the 1990s was not a drug, but a philosophy, the triple bottom line, TBL. While many corporations adopted CSR as a marketing adjunct in the late 20th century, Novo Nordisk integrated TBL, balancing financial, social, and environmental performance into its Articles of Association, making it a legal obligation for the company's management. The genesis of this approach was reactive rather than proactive. In the early 1990s, the company faced significant scrutiny regarding its environmental impact and the use of genetically modified organisms, GMOs, in insulin production. Recognizing that silence was a strategic liability, leadership engaged in proactive stakeholder dialogue. A pivotal moment occurred in 1992 when a delegation of Novo Nordisk attended the United Nations Conference on Environment and Development, known as the Earth Summit, in Rio de Janeiro. Lise Kingo, then Executive Vice President, later described the summit as an eye-opener regarding the magnitude of the global environmental agenda. The realization was that for a biotechnology company to sustain its license to operate, it had to transparently address its ecological footprint. Consequently, in 1994, Novo Nordisk became one of the first companies in the world and the first in Denmark to publish a dedicated environmental report years before such disclosures became mandatory under Danish law. This was not a superficial marketing slogan. It was codified into the company's Articles of Association and bylaws. For a pharmaceutical company in the 1990s, this was a distinct strategic choice. While peers were often embroiled in pricing scandals or ethical controversies, Novo Nordisk's TBL framework provided a license to operate that facilitated market entry. In the US, where the company held only a 25% market share in 2000, this values-driven approach helped attract talent and build trust with healthcare providers who were wary of big pharma motives. A tangible manifestation of the TBL was the company's decision in 1999 to publish its first integrated report, merging its financial and non-financial, social and environmental accounts into a single document. This was a bureaucratic and financial innovation, signaling to shareholders that social and environmental risks were material to the company's financial health. The 1999 report and subsequent iterations detailed the company's environmental footprint, animal testing ethics, and employee engagement metrics alongside traditional profit and loss statements. This transparency was instrumental in securing inclusion in indices like the Dow Jones Sustainability Index, attracting long-term institutional capital that would support the company's multi-decade R&D horizons. By the late 1990s, the TBL had evolved from a reporting mechanism into a strategic framework. The company began measuring success not just by revenue, but by its ability to act as a responsible corporate citizen. This involved complex trade-offs. For instance, in the late 1990s, the company entered into an unprecedented 20-year contract with DONG Energy to purchase electricity from a North Sea wind farm, a move that provided the capital necessary for the wind farm's construction and fundamentally altered Denmark's energy model. This period also saw the formalization of the Novo Nordisk Way, a set of guiding principles that entrenched the TBL in daily operations. The philosophy posited that financial profitability was necessary to fund research, but that the ultimate goal was to defeat diabetes and other chronic diseases while producing zero environmental impact, a goal later branded as Circular for Zero. During this period, the company also launched the Blueprint for Change program, designed to assess and document the value the company created for society. This program was particularly active in the United States, where the company sought to demonstrate that what is good for patients is good for us. By aligning business success with patient outcomes, a precursor to the value-based care models that would emerge 2 decades later, Novo Nordisk began to differentiate its brand in the eyes of payers and policymakers. While establishing its sustainability credentials, the company also diversified its therapeutic portfolio. The 1990s marked Novo Nordisk's entry into the high-value arena of rare bleeding disorders. The cornerstone of this expansion was Novo7, coagulation factor 7A, a recombinant treatment for hemophiliac patients with inhibitors who could not be treated with standard factor 8 or 9 replacements. Designated as an orphan drug in 1988, Novo7 received FDA marketing approval on March 25, 1999. This launch was transformative. It demonstrated that Novo Nordisk could successfully develop and commercialize complex biologics outside of its traditional diabetes stronghold. The success of Novo7 provided a lucrative revenue stream that helped fund the massive R&D expenditures required for the insulin analog pipeline in the subsequent decade. The strategic divergence, creating Novozymes, 2000. By the turn of the millennium, Novo Nordisk was effectively running 2 divergent businesses under one roof: a healthcare business focused on diabetes and growth hormones, and an industrial enzyme business serving the detergent, food, and textile industries. While both relied on fermentation, their business cycles, regulatory requirements, and capital needs were increasingly incompatible. The healthcare business required massive R&D investment with long regulatory timelines, while the enzyme business operated in a faster-moving, commoditized B2B environment. In November 2000, Novo Nordisk executed a strategic demerger, spinning off the enzyme business as an independent entity, Novozymes A/. This separation was designed to unlock shareholder value by eliminating the conglomerate discount. Investors could now value the high-growth pharmaceutical business separately from the steady, cyclical enzyme business. Upon the split, Novo Nordisk's free-float market capitalization was adjusted to approximately €10.3 billion, while Novozymes launched with a capitalization of €1.2 billion. Crucially, the ownership structure remained anchored by Novo Holdings A/, formerly Novo A/, which retained controlling stakes in both companies through A shares with super voting rights. This structure protected both entities from hostile takeovers, a common threat in the consolidating pharmaceutical industry of the early 2000s. It allowed the newly focused Novo Nordisk to reinvest aggressively in its pharmaceutical pipeline without fear of short-term activist investor intervention. The demerger provided Novo Nordisk with financial and operational clarity. Post-2000, the pharmaceutical company could dedicate 100% of its free cash flow to diabetes R&D. This focus was immediately apparent in the acceleration of its insulin analog program. The split also allowed Novozymes to pursue its own acquisitions and strategy in the bio-industrial space, including the settlement of patent litigations with competitors like DSM, the pursuit of bioethanol partnerships with the U.S. Department of Energy, and eventually its own merger with C.H. Hansen in 2024, creating Novozymes. The Moral Crucible, the South Africa Patent Dispute, 2001. In 2001, Novo Nordisk involved in a geopolitical firestorm. The context was the HIV/AIDS pandemic, which was decimating the population of South Africa. In response to the crisis, the South African government, led by the African National Congress, ANC, passed the Medicines and Related Substances Control Act of 1997. This legislation was designed to make medicines more affordable by empowering the government to import patented medicines from other countries where they were sold at lower prices, encourage or mandate pharmacists to dispense cheaper generic versions of prescribed drugs, potentially override patents to allow domestic production of essential medicines. The global pharmaceutical industry, represented by the Pharmaceutical Manufacturers Association, PMA, viewed this act as a violation of the World Trade Organization's TRIPS, Trade-Related Aspects of Intellectual Property Rights Agreement. They feared that if South Africa were allowed to bypass patents, it would set a precedent that could unravel IP protections globally, destroying the incentive structure for drug innovation. Novo Nordisk joined a coalition of 39 pharmaceutical giants, including GlaxoSmithKline, Merck, and Roche, in suing the South African government to block the act's implementation. The companies argued that the act was unconstitutional and deprived them of their property rights. They contended that the high cost of AIDS drugs was due to R&D expenses, not profiteering, and that the act would not solve the lack of healthcare infrastructure. At the time, CEO Lars Rebien Sørensen supported the suit, believing that defending patents was at the heart of what the company was about. The company viewed the protection of intellectual property as a non-negotiable principle, regardless of the therapeutic area. Even though Novo Nordisk was not a major player in HIV/AIDS drugs, the precedent threatened its insulin patents. The lawsuit proved to be a catastrophic miscalculation. The optics of 39 wealthy multinational corporations suing the government of Nelson Mandela while millions of its citizens died of AIDS generated global outrage. Activist groups like the Treatment Action Campaign, TAC, mobilized international opinion, framing the dispute as profits versus lives. By April 2001, the pressure had become untenable. The pharmaceutical coalition collapsed. In what was described as an unconditional surrender, the companies withdrew the lawsuit. The companies agreed to drop the case and pay the South African government's legal costs. In return, the South African government reaffirmed its commitment to WTO TRIPS obligations, but retained the right to use parallel importation and generic substitution to protect public health. For Novo Nordisk, the withdrawal was a moment of profound introspection. CEO Sørensen later admitted, perhaps it wasn't the brightest thing to do, acknowledging that the company had been taken on the wrong foot by failing to see the broader societal context of its business actions. The South Africa crisis catalyzed a permanent shift in Novo Nordisk's corporate philosophy. The leadership realized that legal compliance was insufficient for a healthcare company. It required social legitimacy. To operationalize this commitment and prevent future conflicts between profit and access, the company established the World Diabetes Foundation in 2002. Shareholders voted to allocate a percentage of corporate profits to the WDF, an independent entity dedicated to improving diabetes care in the developing world. The company developed a tiered pricing policy for the developing world, ensuring that human insulin would be available at cost or near cost in the poorest nations, distinguishing its essential medicines from its premium analog products. The Engineering of Delivery and Device Hegemony, 1990 to 2010. While the molecule is the therapeutic agent, the delivery device is the patient's daily interface with the disease. In the 1990s, Novo Nordisk made a strategic decision to commoditize the vial and syringe market and premiumize the pen device market. This strategy was born from the success of the original Novo pen, 1985, and accelerated throughout the 90s. The launch of the Novo Pen 3 in 1992 was a milestone. It allowed patients to dial a dose and, crucially, reset it without wasting insulin if they made a mistake, a significant economic benefit for patients. This durable device was followed by the Novo Pen 1.5 in 1996 and the Novo Pen 3 Demi in 1999, which offered half-unit dosing for children, directly addressing a niche but emotionally potent market segment. In the early 2000s, the company shifted the market paradigm again with the introduction of pre-filled disposable pens. The Flex Pen, launched in 2003, eliminated the need for patients to load cartridges entirely. This convenience came with a strategic benefit. It locked patients into Novo Nordisk's insulin ecosystem. A patient prescribed a Flex Pen could not easily switch to a competitor's insulin without learning a new device, creating a powerful moat around the company's products. This innovation curve continued with the Flex Touch, approved by the FDA in November 2013. The Flex Touch featured a unique spring-loaded mechanism that required no extension of the push button, making it easier for patients with limited dexterity to administer doses. By 2015, Novo Nordisk's device portfolio was arguably as valuable as its chemical portfolio, differentiating its insulins in a crowded market where the molecules themselves were becoming increasingly similar. The Analog Revolution, 2000 to 2010. The 2000s were defined by the transition from human insulin to insulin analogs, molecules engineered to have altered pharmacokinetic profiles. Novo Nordisk's scientists modified the amino acid sequence of the insulin molecule to create rapid-acting and long-acting variants that better mimicked physiological insulin secretion. The first major victory in this era was Novolog, insulin aspart, a rapid-acting analog approved by the FDA in 2000. By replacing the amino acid proline with aspartic acid at position B28, the insulin molecules were prevented from forming hexamers, allowing them to be absorbed much faster into the bloodstream. Novolog became the standard of care for mealtime glucose control, engaging in a fierce decade-long duopoly battle with Eli Lilly's Humalog. While Novolog secured the mealtime market, Novo Nordisk lacked a modern basal insulin to compete with Sanofi's blockbuster Lantus, insulin glargine. This gap was filled with the approval of Levemir, insulin detamir, in June 2005. Levemir used a different mechanism, binding to albumin in the blood to extend its duration of action. Launching in the US in 2006, Levemir was marketed on its unique properties. It was often associated with less weight gain than glargine and had a lower risk of nocturnal hypoglycemia. The approval for pediatric use, ages 2 to 5, in 2012 further entrenched Levemir as the preferred basal insulin for vulnerable populations. This analog portfolio, Novolog plus Levemir, drove double-digit revenue growth throughout the mid-2000s, fueling the company's expansion. Regulatory tribulations, the Tresiba Saga, 2012 to 2016. In the early 2010s, Novo Nordisk's crown jewel was Tresiba, an ultra-long-acting insulin with a half-life of 25 hours. Expected to breeze through approval, the drug hit a brick wall in February 2013 when the FDA issued a complete response letter. The agency demanded a dedicated cardiovascular outcomes trial to rule out excess cardiovascular risk, a requirement stemming from heightened caution following the Avandia controversy in the broader diabetes space. This rejection was a massive blow, delaying the US launch by years and allowing Sanofi's Lantus to remain unchallenged. Novo Nordisk undertook the massive DEVOTE trial to prove safety. The gamble paid off. The data not only confirmed cardiovascular safety, but also demonstrated a significant reduction in severe hypoglycemia compared to glargine. Armed with this data, Tresiba was approved by the FDA in September 2015 and launched in January 2016. The delay had been costly, but the product profile, allowing patients to inject at any time of day, was superior enough to eventually capture significant share. In December 2016, the FDA expanded approval to children and adolescents, further broadening its utility. The oral Grail and technology acquisition, 2019 to 2022. For a century, insulin and similar peptides had to be injected because the stomach's acidic environment and proteolytic enzymes would destroy them before absorption. Novo Nordisk refused to accept this limitation. The company partnered with and ultimately acquired Hemisphere Technologies to utilize their Elegin SNAC technology. The SNAC carrier molecule works by locally buffering the stomach pH and facilitating the transcellular absorption of the semaglutide molecule through the stomach lining. This technological tour de force led to the approval of Rybelsus, oral semaglutide, in September 2019. To secure the future of oral biologics, Novo Nordisk moved to acquire Hemisphere outright in November 2020. The $1.8 billion deal, $1.35 billion for shares plus $450 billion for royalty streams, gave Novo Nordisk full freedom to operate and develop oral versions of its future pipeline without royalty encumbrances. Expanding its technological horizon beyond peptides, Novo Nordisk acquired Dicerna Pharmaceuticals in November 2021 for $3.3 billion. This acquisition brought the Gal-XC RNAi platform in-house. RNA interference allows for the silencing of specific genes in the liver, opening new therapeutic avenues for non-alcoholic steatohepatitis, or NASH, and rare genetic disorders, reducing the company's reliance on the GLP-1 receptor alone. The Incretin pivot, Victoza, and the GLP-1 era, 2009 to 2016. While insulin paid the bills, the future lay in the incretin system. Glucagon-like peptide 1, GLP-1, is a hormone that stimulates insulin secretion in response to meals. However, native GLP-1 is degraded in minutes by the DPP-4 enzyme. Novo Nordisk's scientists engineered liraglutide, a GLP-1 analog with a fatty acid side chain that allowed it to bind to albumin and resist degradation, enabling once-daily dosing. Approved by the FDA in January 2010, Victoza, liraglutide, transformed the treatment of type 2 diabetes. Unlike insulin, which carries a high risk of hypoglycemia and weight gain, Victoza offered glucose control with a low risk of hypoglycemia and the added benefit of weight loss. The launch was not without peril. The FDA required a risk evaluation and mitigation strategy, REMS, due to observations of thyroid C-cell tumors in rodents, a signal that would dog the class for years but never materialize significantly in humans. Despite this, Victoza rapidly captured market share from Merck's Januvia and Lilly's Byetta, becoming the market-leading injectable non-insulin therapy. In December 2014, the FDA approved a higher dose formulation of liraglutide, 3.0 milligrams, for chronic weight management, branded as Saxenda. This was a pivotal strategic experiment. While Saxenda achieved modest weight loss, approximately 5 to 10%, and had significant gastrointestinal side effects, its approval proved that regulatory agencies were willing to treat obesity as a chronic disease requiring pharmacotherapy. This laid the regulatory and commercial groundwork for the revolution that would follow with Wegovy. The Semaglutide Breakthrough, 2017 to 2021. The transition from Lars Rabin Sorensen to Lars Frugaard Jorgensen in 2017 coincided with the maturation of the next-generation GLP-1, semaglutide. By modifying the liraglutide molecule further, scientists achieved a weekly dosing profile with significantly higher potency. Ozempic was approved by the FDA for type 2 diabetes in December 2017. The clinical data from the SUSTAIN trials was overwhelming. Ozempic lowered HbA1c and body weight more effectively than any other drug on the market, including Victoza and Trulicity. While Ozempic was marketed for diabetes, real-world evidence and clinical trials revealed that patients were losing substantial amounts of weight, often 15% or more of their body mass. This magnitude of weight loss was previously the domain of bariatric surgery. Recognizing this, Novo Nordisk initiated the STEP clinical trial program to investigate a higher dose of 2.4 milligrams specifically for obesity. In June 2021, the FDA approved Wegovy, semaglutide 2.4 milligrams for chronic weight management. This approval fundamentally altered the landscape of global healthcare. Obesity was no longer just a lifestyle issue. It was a treatable medical condition with a highly effective pharmacological solution. The demand was instantaneous, cultural, and overwhelming, leading to a phenomenon where the brand name Ozempic became a generic term for weight loss, even by those using Wegovy. The Weight of Success, Supply Chain and Economics, 2021 to 2024. The launch of Wegovy coincided with global supply chain disruptions caused by the COVID-19 pandemic. However, the primary driver of the shortage was the unprecedented demand. Novo Nordisk had underestimated the market appetite for effective obesity treatment. Throughout 2022 and 2023, the company struggled to manufacture enough pen injectors, leading to sporadic shortages of both Wegovy and Ozempic. The crisis forced the company to pause promotional activities and limit starter doses to ensure existing patients could continue therapy. It also spawned a gray market of compounding pharmacies selling unauthorized semaglutide salts, creating a public safety risk that the company had to aggressively litigate against. By 2023, Novo Nordisk's success had macroeconomic implications for Denmark. The company's market capitalization exceeded the entire Danish GDP, $570 billion versus approximately $400 billion. In 2023, the pharmaceutical sector accounted for 2/3 of Denmark's economic growth. Without it, the economy would have stagnated. The massive influx of foreign currency from U.S. sales put upward pressure on the Danish krone. To maintain the currency peg to the euro, the Danish central bank was forced to keep interest rates lower than the European Central Bank, a classic symptom of Dutch disease, where one dominant sector distorts the broader economy. To solve the manufacturing bottleneck, Novo Holdings, the parent company, engineered a massive deal in February 2024 to acquire Catalent, a leading global CDMO, for $16.5 billion. As part of this transaction, Novo Nordisk agreed to purchase 3 key fill-finish sites from Novo Holdings for $11 billion. This vertical integration was a strategic masterstroke, instantly securing huge sterile filling capacity that would otherwise take years to build. The deal faced antitrust scrutiny but was cleared by the European Commission in late 2024, allowing Novo Nordisk to finally declare the shortage resolved in February 2025. Politics, Pricing, and Patents, 2023 to 2025. In March 2023, facing intense political pressure and changes in the U.S. rebate system, Novo Nordisk followed Eli Lilly in announcing drastic price cuts. The list prices of legacy insulins like Novolog and Levemir were slashed by 75% effective January 1, 2024. This move aimed to reduce out-of-pocket costs for patients and preempt further legislative action, effectively ending the era of spiraling insulin list prices. The U.S. Inflation Reduction Act of 2022 fundamentally changed the pricing power of pharma companies. In 2024, CMS selected Ozempic and Wegovy for price negotiations. In November 2025, the results were unveiled. The maximum fair price for Ozempic was set at $274, down from $959, and Wegovy at $385, effective in 2027. While Novo Nordisk publicly opposed the price setting, it accepted the terms, noting the impact would be manageable due to the volume growth expected to offset the price decline. In October 2024, Novo Nordisk secured its near-term future by settling patent litigation with generic manufacturers Mylan, Dr. Reddy's, Apotex, and Sun Pharma regarding the Semaglutide patent, U.S. Patent 10335-462. While terms were confidential, such settlements typically delay generic entry for several years, ensuring that the revenue streams from Ozempic and Wegovy remain protected through the critical late 2020s period. The 2025 Leadership Crisis and Future Horizon. On May 16, 2025, the pharmaceutical world was stunned by the announcement that CEO Lars Fruergaard Jorgensen would step down. Despite his tenure overseeing the company's greatest expansion, the board cited recent market challenges and a share price decline since mid-2024. The catalyst was clear: Eli Lilly. In late 2024, Lilly released head-to-head data from the SURMOUNT-5 trial, showing its drug, Zepbound tirzepatide, achieved superior weight loss, 20.2%, compared to Wegovy, 13.7%. The market perception shifted. Novo Nordisk was seen as losing its technological edge to Lilly's dual agonist approach. The succession crisis triggered a governance intervention. The Novo Nordisk Foundation, utilizing its voting control, installed former CEO Lars Rebien Sørensen onto the board to oversee the transition. This move signaled a return to the aggressive, scientifically rigorous culture that defined the company's earlier years, with a mandate to accelerate the next-generation pipeline. As of late 2025, Novo Nordisk is racing to regain its clinical crown. The future rests on CagriSema, a combination of semaglutide and cagrilintide, an amylin analog. Phase 3 data showed 22.7% weight loss, potentially neutralizing Lilly's advantage. Incretin, an oral co-agonist showing rapid weight loss in early trials, utilizing the oral delivery expertise from the Emisphere acquisition. Circular for Zero. The company remains committed to its environmental goals, having achieved 100% renewable power in production and advancing towards zero CO2 emissions by 2030. From the uncertain days of the 1990 merger to the dizzying heights of 2025, Novo Nordisk's journey is a case study in strategic discipline. By adhering to the triple bottom line, it built a resilient corporate culture. By daring to demerge Novozymes, it sharpened its focus. By betting on GLP-1s when others doubted, it created a new market category. However, the tumultuous events of 2025, the supply crisis, the IRA price cuts, and the CEO leadership shock serve as a reminder that in the pharmaceutical industry, innovation is the only currency that holds value. As the company looks towards 2030, its ability to execute on its new pipeline, CagriSema and RNI, and integrate the massive manufacturing assets from Catalent will determine if it can win the duopoly war with Eli Lilly and continue to serve the millions of patients relying on its proteins.